Hello, everyone. Welcome to today's seminar, which is titled Men versus Women, Differences in Congestive Heart Failure, or CHF, Cardiac Arrhythmias with its CA, and Cholesterol. Go to the next slide. To provide an overview, I'll start by giving a quick introduction, then we'll discuss what congestive heart failure is and the discourse on the differences between men and women. We will then look at cardiac arrhythmia and the following differences, again, between men and women. We'll end off by looking at if there's any sort of sex difference concerning cholesterol. And at points in the presentation, we'll be discussing some general tips for prevention of CHF and heart arrhythmias. And then at the end, we'll discuss if heart vitamins actually work. You can go to the next slide. So you might be wondering why we need to specifically talk about the sex differences when it comes to topics like CHF and CA. This conversation is most linked to predisposed misconceptions about the health issues that men face versus women. At one point in time, it was thought that heart failure and arrhythmias were only a male issue. However, through robust research, we have come to find that overall lifetime risk of heart failure, for example, is similar between men and women. Yet a main caveat to this issue is although likelihood of men and women getting impacted by these heart conditions might be similar, there are slight sex differences which create nuances to certain diagnoses. For example, the symptoms that women experience when it comes to heart failure is slightly different than men, which will be talked about more in detail in the latter slides. Another example is that diabetes increases the risk of heart disease in women more than it does in men, and women who smoke are more likely to have heart attacks compared to male smokers. This has been linked to the fact that women do not respond as effectively to nicotine replacement due to menstrual cycle effects on tobacco withdrawal symptoms. These are just a few examples, but in general, the idea is that knowing these differences not only allow women to be aware of the certain telltale signs, but also help physicians curate treatment plans that work best for individual patients. We can go to the next slide.
Let's just pause. We'll just back up one more. Let's just pause for a second here. Is that so heart disease is just as common in males as in females, but the risk factors are somewhat different. So it's really important to understand that women will pay a higher price of smoking compared to males, and that diabetes is a worsening risk factor for heart disease in males compared to females. And that presentations of heart disease in general. So I always found this quite interesting, is that men are a little bit more straightforward when it comes to heart disease. So if you look at initial presentation of heart disease in males, more men are more likely to present with sudden deaths or a classic heart attack, where women are more likely to present with funny chest pains called angina. And so it can be hard to make the diagnosis of heart disease in women compared to males. You know, if you're dead, you're dead. That's easy to count. Heart attacks, we can measure the ECG and the blood test called troponin values. That's an easier test to measure. But chest pains, discomfort in the chest, that shortness of breath, that tightness in the chest, is that heart disease or is that something else? Is much harder to make that diagnosis. So I think most clinicians are attuned to that at this point in time, and I think you as viewers need to understand that differences. So to me, the classic presentation of heart disease or blocked arteries, I get this tightness in my chest that occurs with activity. It gets better with rest. If you complain of those symptoms, you need to get that investigated. If you burp the wrong way, if you're short of breath, that can be deconditioning, it can be indigestion. It's hard to get diagnosis. And so we need to be attuned to that. But it's really important to understand that on average, women develop heart disease 10 years later compared to males. It kills just as many males compared to females. But it's interesting that diabetes carries a higher risk and smoking carries a higher risk in our female population. So whether or not that's a hormonal change or not, I don't think we know that right now, but these are facts that we need to be aware of. Thanks so much. Tell us more.
All right, so what exactly is congestive heart failure, otherwise known as heart failure? Go to the next slide. Contrary to what people may think, heart failure does not mean that the heart stops working. According to the Mayo Clinic, this is a phenomenon when the heart muscles do not pump blood well enough. This can lead to blood to back up. Overall, the heart muscles become less capable of contracting over time. Thus, the heart can't keep up with the body's demand, causing the blood to return to the heart faster than it can be pumped out, therefore becoming congested. There are several repercussions. For example, fluid can build up in the lungs, which can cause shortness of breath. The extra effort that the heart partakes in can cause heart palpitations. The heart can also enlarge a little bit to make room for the blood. Also, kidneys can get impacted if they're not receiving sufficient levels of blood because they'll start to retain water and sodium, which can lead to kidney failure. Overall, heart failure is a serious condition, which is often progressive, meaning it gets worse over time. You can go to the next slide. Some of the general symptoms are displayed on the slide. So this includes shortness of breath, weakness, swelling in the legs, ankles, or feet, rapid or irregular heartbeat, reduced ability to exercise, persistent cough, swelling of the belly, very rapid weight gain, nausea and lack of appetite, as well as difficulty concentrating. It is important to note that symptoms can vary depending on the person, and it's best to contact your doctor with any concerns. We can go to the next slide.
Let's just backtrack a little bit over here. So let's explore this a little bit. You can see these are very non-specific symptoms. You know, shorter breaths. I could be just I'm deconditioned. I could just have anemia. I could have renal dysfunction. Palpitations are relatively common. Cough. Do I have COVID? Do I have a bronchitis? Do I smoke too much? Swelling of the legs is actually worse in the summertime, and especially if you're overweight. Some days I feel confused most days of my life, and then sometimes I'm fatigued because of poor sleep. But something I'll just tell that you should really be attentive to is you want something that's a change in your normal pattern. For instance, if you just gained, 5 pounds and you're not eating more, and your legs are more swollen. And one of the things that's really important is that normally I can lie flat in bed, but now when I lie down in bed, I get shorter breaths and I have to sleep on a couple pillows. And I now have to sleep in a chair where before I can do that lying down. So that in my mind, when I see this clue that I can't lie flat anymore, I get shorter breaths. And in the past, I can sleep on one pillow. Now I sleep on 2 or 3 pillows. That's most of the time that's congestive heart failure. So those are some pearls. A lot of us gain weight. I can be 5 pounds up morning, afternoon, depending, how much activity I'm doing. But if I'm consistently gaining weight and my legs are swollen, that's also could be a clue of heart failure. Also could mean that I'm just gaining weight. I didn't realize what we're doing. So people with congestive heart failure often weigh themselves. They should weigh themselves almost daily. And you could be taking certain medications called a calcium blocker. That's a blood pressure medication, things like diltiazem, norvasc, amlodipine, cardizem, verapamil. These medications are good blood pressure lowering medications and good medications to treat angina, but they also could cause leg swelling. And leg swelling is often more common in the hot, warm weather as well. So there's other things that can cause leg swelling too as well, or I'm just overweight, deconditioned, haven't exercised. My veins in my legs don't return my blood supply. So there's multiple reasons, and that's why you have to be your own health detective. But these are some of the clues that we have. Tell us more.
So the best way to avoid CHF is through preventative methods. So this includes to stop smoking, or actually better yet, not start smoking at all, as it's been linked to arterial damage that causes heart failure. Another important aspect is your diet. So it's important to consume foods that contain little saturated fats, trans fats, sugar, or sodium. So including a lot of fruits and vegetables, low fat dairy, lean protein, and of course, getting physical activity is always recommended. In terms of treatment, in some cases, individuals may qualify for surgical procedures, but often people will be placed on medications. So just a few examples are vasodilators, which ease blood flow, as well as beta blockers and ACE inhibitors, which improve heart functions. You can find videos on these and other medications on Dr. Curnews' YouTube channel and more in depth. Go into the next slide.
Backtrack again. One more thing to remember here. If you don't succeed, try again. Smoking, for instance, every time you smoke, you will lose 5 minutes of life. I'll repeat that. For every cigarette that you smoke, the calculation is 5 minutes of life. If you smoke, 60% chance smoking will kill you at some point in time. So this is a serious problem. Most people don't want to smoke who smoke. And most people take about 6 or 7 serious smoking cessation tries before people can kick the habit. And you can kick it for 1 day, 6 years, 6 months, whatever it takes. I'm going to give an example is that I'm trying to learn how to fly a plane glider. I'm at 71 flights. I still don't know how to fly a plane, but I'm getting better at it, and I'm enjoying the journey. So really don't give up on something. Exercise. This is something that is underestimated from basically your psychological benefit. It's probably the #1 way to improve your quality of life if you have congestive heart failure. It's important. Well, we talked about diet and exercise. These are pillars of health. And if we don't fix these foundations, it's going to be very hard to live a healthy, prosperous life. Yeah, we have wonderful medications, and they'll help. They'll make a difference. But the backbone, the foundation, are really important. So I can give you medications, I can make the diagnosis, but don't forget about the foundational feeling. Yeah, just treat the foundation, and they're so underemphasized. If walking 2 minutes 5 times a day is a good starting point, but just don't give up on it. So please, please, please think about how that should be incorporated. And next slide, please. Take it away.
So now we can take a look at how congestive heart failure is different between men and women, some of the symptoms and risk factors and things like that. So as we mentioned just a couple minutes ago, congestive heart failure is not just a man's disease. By 40 years old, men and women, they have just about an equal lifetime risk of developing heart failure, which is about 1 in 5. But there are differences when it comes to how it presents, when people develop it, risk factors, things like that. Women generally develop heart failure at an older age compared to men, as we mentioned just a couple of minutes ago. And men and women are also generally predisposed to a different type of heart failure. If we go to the next slide now, just talk about.
Hold up, come back. This is so good. This is really important, and thank you for sharing the slide. You're telling us that 1 in 5 or 20% of us will develop congestive heart failure in our lifetime. I'm going to tell you is that number is a growing number, and that if everybody lives long enough, you will die from congestive heart failure. The reasons for that is that when I first started my practice, is that heart attacks were a big problem. Now that we lower cholesterol, lower blood pressure, people are eating better, weighing less, and especially cholesterol medications. Remember that high dose of a statin and 10 milligrams of ezetimibe can lower the risk of a heart attack or stroke by 60%. So we've done a really good job of preventing heart attacks or treatment of heart attacks. We have better treatment of this. Because we have better treatment, is that the heart wears out, and you're going to tell us about this in a little while, is that you're going to die of congestive heart failure at a higher probability. So in a sense, it's been a success of our treatment of heart disease because we prevent the heart attacks, and we have better therapies for heart disease. But as we get older, the heart will wear out, whether stiffen up or will have damage to the heart. It's going to show us in a few minutes, for a few seconds from now. So I'm pleased to say that incidence of heart failure is a success of medicine, and it's a failure of what we can do as well. So you're saying the number is 1 in 5. I'm going to say right now is that the 2 leading causes or major leading causes of deaths right now will be with heart failure. And now we all know that infectious disease, like getting pneumonias, pneumococcal pneumonia can lead to heart attacks and congestive heart failure, can lead to atrial fibrillation. Influenza, which is about to embark of us, is that in the week or 2 after influenza, you're 7 times more likely to have a heart attack, more likely to have congestive heart failure. Same thing with COVID as well. So they're all intertwined, interconnected. So thanks for sharing this. Tell us more.
Yeah, so if we go to the next slide, I'll just talk about the different types of heart failure that men and women are predisposed to. Women usually predominate in heart failure with something called a preserved ejection fraction. And so this is also known as diastolic heart failure, whereas men generally get heart failure with a reduced ejection fraction, which is also known as systolic heart failure. So in general, and the ejection fraction is a measure of how much blood inside your ventricles and your heart heart are actually pumping out blood. So when your heart contracts normally, the ventricles squeeze out only a portion of the blood inside those ventricles. It's not pumping out all of the blood. So a normal ejection fraction is above 55%. So that means that 55% or more of the blood inside those ventricles are getting pumped out every time the heart contracts. So in diastolic heart failure, where we have that preserved ejection fraction of greater than 55%, the ventricles become really stiff and they can't relax normally. So this means that the ventricles are not filling up with as much blood. And so when the heart contracts, less blood is generally getting passed through the heart. So you can see that in the picture on the left there, the ventricle walls look pretty thick and the ventricles themselves, they look smaller in volume. So in systolic heart failure, where we see that more in men, we have the ventricle walls actually getting thinner, as you can see in the picture on the right. And so because those walls are thinner, the heart can't generate as much force to actually pump out that blood. And so again, the heart just generally can't pump as much blood out of the heart effectively anymore. There's a reason why we see this difference in the type of heart failure that men and women develop. If we go to the next slide, basically when we have hemodynamic stress, which basically just means when the blood in your cardiovascular system is exerting a lot of force on your heart and your blood vessels, the heart muscle in men versus women responds differently to that kind of stress. So in women, we see something called concentric remodeling. So you can see that in the picture on the top left here. So when there's a lot of stress on your heart, the ventricle walls almost get thicker. And if you can imagine your ventricles in your heart kind of being like a cup, the cup inside, it can hold less fluid inside. So it's just kind of getting smaller, as you can see in that top left. But with men, we see something called eccentric hypertrophy. So that's on the bottom right picture here. The entire ventricle kind of gets bigger. And so we see generally in men, the volume of those ventricles getting bigger, but the ventricle walls getting thinner. So less blood, again, is being pumped effectively. So we can go to the next slide as well here. I just wanted to return back to those symptoms and how they can be different between men and women. We talked a bit already about the symptoms that we can see in congestive heart failure. So there's a few other examples here. But generally, women have a more severe symptom burden. So they kind of experience the same symptoms, but it's just more severe. So more swelling, more shortness of breath, more fatigue, things like that. And so women generally report having a lower quality of life because of these exacerbated symptoms, but generally they have a lower mortality rate compared to men. And something else that I also wanted to note while we're talking about symptoms is that symptoms of congestive heart failure in women are often missed or misinterpreted, sometimes as bronchial asthma, as opposed to cardiac asthma because of congestive heart failure. And so this generally means that women experience a delay in diagnosis and treatment for congestive heart failure.
So we can pause here for a sec here. So these symptoms that you mentioned, I think you showed really nicely a thickened heart muscle. So you can think that will thicken your heart muscle or any muscle if you overwork the muscle. So you get that from high blood pressure, is a good example, and you get that from being overweight, as well as your valves wearing are a couple examples. But you also get these symptoms from just deconditioning. And one of the things that Jerry and his team from the exercise and the mindfulness group reminded us is that between the ages of 20 to 70, we lose 50% of our muscle mass. So if your muscles aren't as strong, you'll get shorter breath, you'll get fatigue, you'll get weakness. And the only way to really make a big impact is to actually preserve. So you are young people between the ages of 20 and 30, your peak performance. And that's why you can see not too many people win gold medals in their 30s or 40s or 50s, is because your muscles are getting weaker as time goes on. And my plea to everybody is to really think about how to incorporate activity. We showed in our last webinar, look, I did the Toronto half marathon. I finished towards the end of the pack, but I did it. And if I can do it, you can run your own marathon at your own speed. So this is a huge plea to everybody, is if you have a weight problem, think about how to deal with that. It's taking me 71 flights to learn how to fly. I still don't know how to fly. If it takes you 100 different times, 2,000 times to learn to lose weight, then keep learning. There's so many tricks to the trade, and activity is a great component. I'm going to bring in the word called MET. 1 MET is your basic metabolic rate. You need 5 METs to accomplish just daily activity. And to be fit, you want to be over 12 METs of activity. So we do stress tests on people, and you can actually calculate METs. I want you to think about when you had your stress test, if you ever had one, how many METs of activity you can do. For every 1 MET increase in activity, mortality from heart disease falls by about 10% in observational data. So one thing is that I could have congestive heart failure, or I just kind of lost 50% of my muscle mass because I'm going to think about exercising later. Exercise is the best way to delay that and build some of that back. And especially if you have congestive heart failure, you can improve your fitness. And you show us very nicely that women pay a higher price. They feel worse compared to men for their so-called diastolic heart failure or thickened heart problem. And so exercise is an integral component of this. The medications will be helpful, but to be honest with you, is that exercise is by far one of the most important things you can do. Remember, if you put a healthy person to bed rest, you take a bunch of 20-year-olds, you put them to bed rest for a week or two, you lose about 25% of your fitness very quickly. It takes a long time to rebuild that. So keep talking, but remember this is people who have congestive heart failure, especially diastolic heart failure, have multiple diseases, and one of them is deconditioning. Thank you. Keep going.
Perfect. So now I just quickly wanted to talk about different risk factors for men and women. We started talking about this a little bit before at the beginning of this webinar, but there are some traditional risk factors that impact both men and women. And generally, these risk factors tend to predispose women to a greater extent than men. So some of these include hypertension, diabetes, obesity, atrial fibrillation, tobacco use, things like that. And to just give you an example of how it predisposes women to a greater extent, if we take hypertension, having hypertension increases the risk of developing heart failure for women by 3-fold, whereas it's about 2-fold in men. There are also some risk factors that are specific to women. So for example, if we take menopause, while women are premenopausal, estrogens actually stimulate the dilation of your blood vessels, and this helps reduce vascular stiffness. But with the onset of menopause, we have that drop in estrogen, and this leads to blood vessels becoming more stiff, less elastic, and this leads to a higher blood pressure, and it places more strain on the heart. There are also some risk factors that relate to pregnancy, one of these being preeclampsia, which is a serious pregnancy complication that causes hypertension and proteinuria, which is the presence of protein in urine. Preeclampsia has been associated with a 4-fold increase risk of developing heart failure in the future. So if you are pregnant or you want to get pregnant, it's really important that you minimize your risk for developing preeclampsia by eating healthy, exercising, talking to your doctor about minimizing your risk factors, like managing your blood pressure, things like that. And one other thing I wanted to talk about while we're on the topic of pregnancy is peripartum cardiomyopathy, which is a type of heart failure that can arise sometime in women between the final month of pregnancy and about 5 to 6 months postpartum. And peripartum cardiomyopathy is a type of heart failure where we have a reduced ejection fraction. So basically the walls of the ventricles get pretty thin, and so the heart can't generate as much force to actually pump blood out of the heart. And so we get that congestion happening there as well.
Catherine, thanks for sharing this. So a couple of things to remember is that you can see that how high blood pressure makes a difference. Ideal blood pressure 110/70. Anything north of that increases your risk of developing congestive heart failure, stroke, and heart disease as well. And so I don't know why everybody doesn't have their own blood pressure machine. If you're just going to wait for the blood pressure to be measured at the doctor's office, you're missing out on your health. So everybody should have a scale, best body mass index 20 to 25. We can measure for blood sugar, for hemoglobin A1C. Now, if you develop atrial fibrillation, that irregular heartbeat that you showed us here nicely, is that your mortality doubles. Atrial fibrillation means something's wrong with the heart. We give blood thinners to prevent stroke, but it's on a pathway to congestive heart failure. And I think one of the things that we just learned recently, and thank you for bringing this to attention again, Catherine, is that women during pregnancy, if you develop high blood pressure during your pregnancy, especially if you develop high blood proteinuria, any degree of high blood pressure during pregnancy increases your risk of future heart disease. If you develop diabetes, gestational diabetes, it goes away often after pregnancy, but it's a marker for future diabetes, it's a marker for future heart attacks and strokes. So if you have illness during pregnancy, from blood pressure to proteinuria, or you get this very serious condition called cardiomyopathy, you're in higher risk for heart disease and stroke in the future. So my plea for women who are planning to have children is get yourself in fighting shape before you get pregnant. Because pregnancy is hard on your cardiovascular system. The baby always wins. It will take what it needs to sacrifice mom. So for mom to be ready for pregnancy, mom has to have her weight in control, her blood pressure to control, make sure she doesn't smoke, because if she smokes, the baby smokes. If she drinks, the baby drinks. We all realize that. If you have high cholesterol, the baby has high cholesterol too as well. And growing at the appropriate weight, not too much, not too little, because the baby will suffer and so will you. But if you do develop high blood pressure, you do develop diabetes, then you need to work on your health, because this is going to come back and haunt you and shorten your life later in life, because you want to be around for your kids and your grandkids. And so this is a marker for things to think about. And thank you again for sharing that, Catherine. Tell us more.
Thank you for teaching us about heart failure. So now we will be moving on to cardiac arrhythmias. We're going to be talking about what they are, how they're caused, how physicians monitor them, as well as the various different types of cardiac arrhythmias. So if we go to the next slide. Before we discuss and dive into what cardiac arrhythmia is, I believe it's useful to understand what the heart rhythm is and how it's produced in relation to the heart's electrical conduction system. So the rhythm of the heart is set by a small region of cardiac muscle cells in the right atrium, and that's called the sinoatrial node. It's also known as the natural pacemaker of the heart. So this section in the heart, it initiates spontaneously, but it is under the control of nerves such as the vagus nerve and circulating hormones such as epinephrine, and these control your heart rate. So the normal heart rhythm is called a sinus rhythm. In the sinus rhythm, each beat is spontaneously generated from the SA node, and this propagates and produces a wave of bioelectricity that spreads throughout the 4 chambers of your heart. So that's the 2 upper atria and the 2 ventricles down below, and they spread it in a coordinated fashion. So the network starts in the upper portion of the right atrium, where the SA node is located. It initiates an action potential about every 0.6 seconds, and it propagates throughout the atria via something called gap junctions, and it spreads out to contractile fibers, and this leads to the contraction of the atria. The action potential then reaches the atrioventricular node, and this is located in the interatrial septum. And this is the only point where the action potential can actually conduct from the atria to the ventricles. And it then enters the atrioventricular bundle, and it's also known as the bundle of His, followed by the continuation into the left and right bundle branches, and this extends down towards the apex of the heart. It then continues on to the large diameter Purkinje fibers, where the action potential will then be rapidly conducted from the apex of the heart up towards the ventricles, and this causes them to contract. So if we move on to slide 3 now.
Backtrack one more time. Yeah. The heart's the most beautiful machine I've ever seen. It is complicated. It's an electrical critter. It has all these wiring systems, and it also has these efficient pumps that pumps on average 60 times a minute, 24 hours a day, 7 days a week for the rest of your life. Take care of it. Yes, it's a little bit complicated, some explanations here, but the heart's both electrical, it's a pump, it's beautiful. And keep your heart beautiful. Take care of your heart. Tell us more.
Right. So now comes the big question. What is cardiac arrhythmia? So cardiac arrhythmia is an abnormal rate and or rhythm of the heart due to its abnormal electrical impulse, origination, and or propagation. So to diagnose an arrhythmia, physicians will typically monitor the heart rhythm through the use of an electrocardiogram, also known as ECG. And this measures the voltage between different points on the surface of your body, typically the chest. So a normal electrical record will appear as seen in the picture on the right-hand side of the screen, and deviations are often a sign of arrhythmia. So on the screen, you can see a fast heartbeat and then a slow heartbeat. Other diagnostic devices include the Holter monitor. So this is essentially a portable ECG, and it's worn from up to 1 to 2 days or even 2 weeks. And you can do everything but shower or bathe while wearing these electrodes. Another device is the echocardiogram, and this test uses the ultrasound to check the heart muscle and valves. As for the way that arrhythmias can be classified, there are multiple, for example, by heart rate. So we have something called tachyarrhythmias, and these are rhythms with in which the heart rate is faster than normal, usually taken as greater than 100 beats per minute, and they're further classified based on where they arise. So they can be ventricular, meaning within the ventricles, or supraventricular, so anywhere above the ventricles. And some arrhythmias that are classified under tachycardia are atrial fibrillation. So this is when you have a chaotic heart signaling and it causes a rapid and uncoordinated heart rate. And it's associated with very serious complications such as stroke. We also have ventricular fibrillation. And this is a type of arrhythmia that occurs with rapid and again, chaotic signals, but this time it causes the ventricles to quiver instead of actually contracting in a coordinated way that the blood gets out and pumped to the rest of the body. So in this situation and scenario, the blood is not being pumped to the rest of the body. Another way to classify these arrhythmias are bradycardias, and this is when the rhythm of the heart is decreased to below 60 beats per minute. So this may arise because the sinus rhythm is usually slow. However, not all slow heart rates are associated with impaired cardiac function. So for example, if we take an athlete, many athletes actually have normal heart rates below 60 beats per minute. And this is because their heart is capable of pumping that adequate amount of blood below that limit. A type of bradycardia is the sick sinus syndrome. And this can be caused because of scarring near the sinus node, and it causes slowing or disruption or blocking of the traveled impulses of the bioelectricity. So moving on to slide 4 now. So how do these types of arrhythmias differ between females and males? So atrial fibrillation is one of the most commonly encountered tachyarrhythmias in clinical practice. The incidence of atrial fibrillation per 100 person years is reported to be between 1.6 and 2.7 in women, and between 3.8 and 4.7 in men. So men are at a higher risk when compared to women. And in one study, men were shown to have 1.5 times greater risk of developing this arrhythmia than women did. However, when atrial fibrillation is occurring in women, the survival rates and the risk of death is much higher in women than in men. And also because there are almost twice the amount of women than men older than the age of 75 years in the general population, the absolute number of women with atrial fibrillation is in the older age groups exceeds that of men. So moving
So
on.
it's interesting that, go back one more time. So you mentioned atrial fibrillation. So atrial fibrillation is the most common rhythm disturbance that we see in clinical practice as a heart doctor. It is relatively rare in young people, relatively more common as we get older in life. It means that the heart something's wrong with the heart. So it's working at a higher pressure, there's a valve problem, you drink too much, you have high blood pressure, you're overweight. Remember, if you have atrial fibrillation, your chance of dying has just doubled. And we treat atrial fibrillation to prevent stroke, but also People say, well, now that I have atrial fibrillation, what do I do? Well, the problem is preventing atrial fibrillation. So it usually starts off intermittently, then it becomes continuous over time. So if you're in the process of developing extra heartbeats, palpitations, you mentioned the Holter monitor, we can actually start measuring them. And over time, up to 90% of us have extra heartbeats. And the more you have, the more you develop atrial fibrillation over a lifetime. So the best way to treat atrial fibrillation is to prevent it. So number one, don't get older. I don't know how to stop the aging process too well, but keeping your weight down. And we know that people who keep their weight down will have less atrial fibrillation. Measure your blood pressure, control your blood pressure. If you have sleep apnea, there's some data that sleep apnea control makes a difference, but lowering weight makes a difference. Controlling blood pressure makes a difference. And no alcohol. For every drink that you have, you increase the amount of atrial fibrillation. So we have a randomized trial that took people who were drinking about 15 drinks a week, and they're randomized to no alcohol versus continue their alcohol intake, with randomized data showing about 20 to 30% of recurrence of atrial fibrillation was decreased by restricting alcohol. So to me, is exercise, blood pressure, weight control. We talk about this foundation. Once you have atrial fibrillation, you're going to have more atrial fibrillation. So the best way to treat is prevent it. A good doctor, a good patient makes a good diagnosis. A better doctor, a better patient prevents the problem from happening in the first place. So keep telling us more, and just think about in your journey, how you're going to prevent your atrial fibrillation. If you have it, we'll treat it. Let's try to decrease the amount of it. Tell us more.
Yeah, so bouncing back to the general symptoms associated with cardiac arrhythmias, you may feel a presence of a fluttering or racing heart, and in some cases, this might be harmless, but some heart arrhythmias can cause some bothersome signs and symptoms. So please note also that patients with cardiac arrhythmias experience a wide range of symptoms, so it's best to consult a doctor. But in general, the signs and symptoms do include either a racing heart or a slow heartbeat, some chest pain, shortness of breath, fatigue, lightheadedness or dizziness, some sweating, and even some fainting or near fainting. And there are multiple risk factors for cardiac arrhythmias, and this includes things like age. So as Dr. Curnew mentioned, as you get older, your risk will increase. Some factors such as genes, so your odds might be higher if you have a close relative that has an arrhythmia, and things like the environment as well. So the world around you, like air pollution, can make arrhythmia more likely. So what are some other risk factors of arrhythmias? The things that make you more likely to have arrhythmia include your history of, for example, high blood pressure, and this increases the risk of developing coronary artery disease. It may also cause the walls of the lower left ventricle to become stiff and thick, and this can change how the electrical signals are traveling to the heart. And furthermore, another example is electrolyte imbalances. So substances in the blood called electrolytes such as potassium, sodium, calcium, magnesium. These are some substances that help trigger and send electrical impulses to the heart. So if you are experiencing an imbalance in electrolytes, this can interfere with the heart signaling, and it can lead to irregular heartbeats. So when is it time to see a doctor? Well, generally it's good to book regular checkups with your doctor, but here are a good few signs to look out for. As mentioned, the general symptoms: racing heart, slow heartbeat, chest pain. But one type of arrhythmia called ventricular fibrillation, as mentioned before, it can cause a dramatic drop in blood pressure. And as a result, the heart doesn't pump blood to the rest of the body, so you may collapse. So keep an eye out for lightheadedness and dizziness. And while cardiac arrhythmias can go unnoticed and without side effects, there are various complications that can arise due to cardiac arrhythmias. For example, they are associated with an increased risk of blood clots. So if a blood clot breaks loose, it can travel to the brain and cause a stroke. So that's a very serious matter. And moving on to slide 6.
So you mentioned some very interesting things about rhythm problems. So if you have atrial fibrillation, that means your small chambers called the right and the left atrium are not beating properly. They're beating in a chaotic fashion, at least the things like blood clots and symptoms. and that you have on blood thinners, and we have something called the CHAD scoring system. So if your old age is 65, you have high blood pressure, you have diabetes, you had a TIA or a stroke in the past, you need to be on blood thinners for the rest of your life. Atrial fibrillation can be intermittent or permanent. And we know that people who have atrial fibrillation, 90% of atrial fibrillation is asymptomatic. So that's why you need to investigate at the right time. Again, many of us, we all have palpitations. You know, I get stressed. I'm trying to fly my glider. My heart starts to race. That's just normal heart rate increase because I'm stressed at that point in time. But if you do something abnormal, it just starts to race for no particular reason. By the way, many of us can feel our heartbeat at nighttime when we're nice and relaxed. That's normal. That's good. It means your heart's beating and you can finally hear that. So it's being a good detective about this. Now, you mentioned the word ventricular fibrillation. If your ventricle fibrillates, that means there's no meaningful blood supply from the heart, you die. And the only way to treat that is by a shock, CPR, being in the right place at the right time. Ventricular tachycardia is another serious rhythm problem where the large chambers are beating too fast and not in a synchronized fashion. So that's why atrial fibrillation is one that's more symptomatic because it's the small chambers that are not pumping properly and the big chambers still work, so you get a reasonable blood supply. But if the big chambers fail, unfortunately, that leads to sudden deaths, and that's why we have prevention of that. So that's a separate talk and discussion, but basically take care of yourself. We were shown a beautiful pumping heart with all the Purkinje fibers and the valves, and just take care of it. Mother Nature did a great job. Most of us have a garden, take care of our gardens, but you don't take care of your health the same way. Gardening, by the way, is good for your heart. Keep telling us more.
Okay, so now that we know some of the general symptoms, how do they differ from men to women? So women with atrial fibrillation are likely to present with an increased palpitation and anxiety compared to men. So this is seen with the shortness of breath, fatigue, and dizziness. And of the various complications of atrial fibrillation, thromboembolic stroke is one of the most devastating, and many retrospective studies have demonstrated that females are associated with a higher risk of thromboembolic events when compared with men. And for some reason, that studies also show that for reasons that may be related to cultural or sex bias, women with atrial fibrillation are generally diagnosed later in their disease when compared to men. And I think, Catherine, you also mentioned this, a similar scenario with congestive heart failure. And they also may be referred less frequently to specialized centers or clinics for the management of their arrhythmia. So moving on to slide 7, talking about the treatments.
Just back up a little bit. I just think that you mentioned that women present later in life, so they're older. They have more medical problems. They have more arthritis, they're not moving. They have more lung disease, more kidney disease, more anemia. It's actually, when you have so-called diastolic heart failure, you have multiple diseases. You usually have, we call the sarcopenia of inactivity. You lost a lot of muscle mass. You may have a lung problem. You may have a kidney problem. You might have an anemia problem. So there's so many different things in that. So no one goes out of their way to say to misdiagnose. It's just hard to make a diagnosis, and you have to actually understand your body and see when there's a changing effect. But you also have to take care of your body. You know, you need better maintenance as you get older. Your car gets better maintenance as it gets older. Your body needs more maintenance as it gets older as well. So have your blood pressure machine, have your scale, eat well, exercise. One of the things, I'm having my coffee over here. So this is actually my second cup of coffee today. So we learned last week that 2 to 4 cups of coffee is now a health food. I put a little bit of skim milk in mine today. By drinking it later at nighttime, what will happen is I'll sleep 30 minutes less on average compared to not drinking it at nighttime. But I'll concentrate better, so I'm more attentive to this webinar, so I have better concentration powers at this point in time. And for some people, it may cause palpitations. For me, coffee doesn't cause me. It gets me to study more and be more excited about learning about this webinar. And if you do have symptoms of palpitations, well, the best way, you mentioned that Holter monitor. There's between a 1 day to 2 week Holter monitor that can be put on. You can get something called an Apple Watch at this point in time, or the cardiac monitoring device. We have a bunch of cardiac monitoring devices too that we can share with people from time to time. We're now going to, if you don't have your own blood pressure machine and you feel you can't afford to get a blood pressure machine, we'll lend you a blood pressure machine for a month or so if you'd like, but you have to measure your blood pressure. And so my blood pressure is 126/78. And when I'm relaxed, when I'm hyper, it goes up to about 190 or so. That's not high blood pressure. It just means that my blood pressure is responding to a stressful environment. So blood pressure should go up or down. And but atrial fibrillation is that 5% of people over the age of 65, 75 will have atrial fibrillation. It's a disease as we get older in life. And again, good sleep, keeping your weight down, alcohol restriction, blood pressure control, and regular exercise have a huge impact on developing atrial fibrillation. And once you have it, you're at risk of having a blood clot. You're at risk of dying. So let's prevent it. And if you do have it, let's treat it. Tell us more.
So right on that topic, we're going to be talking about the treatments for females and males. So there are many options available. For example, cardiac arrhythmias are associated, as mentioned before, with an increased risk of blood clots. So blood thinners can be used to lower the risk of strokes. However, your doctor will need to determine if a blood thinning medication is right for you. Other heart arrhythmia treatments may include medications such as the one listed on the screen, catheter procedures, pacemakers as well, and those are implanted devices to control or eliminate the fast, slow, or irregular heartbeats that you may be experiencing. When compared to men, women typically received less minimally invasive therapies, according to various studies like cardiac ablation, and this eliminates the irregular malfunctioning tissue, and it allows irregular heartbeats to occur. So once the tissue is destroyed, the heart's electrical signals are normalized so the heart can beat normally again. And like Dr. Curnew mentioned, the best way to avoid these is with a preventative lifestyle. So a heart-healthy lifestyle can also help prevent heart damage that can trigger certain heart arrhythmias. And these include things like eating a heart-healthy diet, so limiting or avoiding caffeine and alcohol intake, staying physically active, maintaining a healthy weight, and things like not smoking. If you would like, we also, Dr. Curnew's club has an exercise club and smoking cessation club. So those are also great resources. Check them out. And that is a little bit about the treatments for males and females.
It's kind of interesting if you go back to that slide about medications there. We have very effective medications. One of the things, if you have atrial fibrillation over the age of 65, you have high blood pressure, you have diabetes, you had a stroke or warning stroke, you need to be on blood thinners for the rest of your life. And then we have to control heartbeats and things of that nature as well. It's kind of interesting how we've gotten into things about medications, is that many people stop their medications and run out of pills. And if you run out of gas, you're in trouble. And the gas station doesn't call you up and saying, I'm running out of gas, come get filled up. But when it comes to medications, people have sort of taking their foot off the accelerator. They're relying on somebody else to be in contact. And one of the things, I want to be making your diagnosis of atrial fibrillation. I want to treat your medical problems and prevent you. But right now we're being bogged down where people say, well, I'm running out of pills, the pharmacy will call you. Well, the gas station doesn't call you when you're running out of gas. So really be attentive, learn what your medications are doing, learning when you're going to be running out of medications. And your next appointment with me or your doctors is decide who's prescribing what, and let's review the medications at the right medication at the right time. And I will give you a year's supply plus of all the medications that I'm responsible for, so you never run out. And you should never have the pharmacist call my office to renew your medication, because I want to treat you and prevent you from getting sick. And a pharmacist faxing in a prescription renewal that I haven't talked to you about, well, I don't know if you still need the medication, the right dose. It's bad medicine. So be in charge of your medications. If you can't be in charge, find somebody else in your family. to be in charge of this. And don't run out, and don't expect somebody else to remember when your renewals are. You need to know that. That's a plea. And you mentioned caffeine. Caffeine rarely leads to atrial fibrillation. Alcohol does. Caffeine may make your heart rate speed up a little bit of palpitations, but for me, it provides me with better concentration, better alertness, and I got to watch how it affects my sleep a little bit. So I got to learn to get better quality sleep. So that's what I'm working on, and everybody can figure out that themselves. Keep going. Nothing good about smoking. Keep moving forward. And again, it's hard to stop, but you know what? If I can learn to do things better, so can you. And just enjoy the process, and just get on with it. And just people in healthcare have this lifelong learning. You should have lifelong learning, and one of them should be learning about your health. And thank you for showing us about difference between males and females when it comes to heart disease. You mentioned things like atrial fibrillation, congestive heart failure. So much to learn, and thank you for shedding that light. And one of the new knowledge is to me in the last 5 years that if a woman had complications during pregnancy of high blood pressure, diabetes, this is a marker for future heart disease later in life. I didn't know that 20 years ago. I know that now, and you should know that too as well. So when you were having your children, or if you're planning to have children, get yourself in good shape before you plan to have children. And if you did have complications, is that you're at long-term risk for future problems, but that can be treated and prevented. One of the things I heard from so many people, well, the diabetes went away, I'm okay. You're not okay. It means that we have to work. Your pancreas is not a well pancreas. And during pregnancy, that affected you. Your requirements for insulin are up during pregnancy, and you're going to have problems later in life. So, but you can actually deal with that. And there's great strategies to put diabetes into remission. If you lose 20 or 30 pounds and you're overweight, you can put 50% to 7% of diabetes into remission for a period of time. So, just saying I'm going to exercise later, I'll worry about this later. It's, then I get my atrial fibrillation, my congestive heart failure. Remember, once you have congestive heart failure, 50% of people unfortunately pass away within 5 years. So we have good treatments, but treatment and prevention are so key to success. And thank you for sharing that. Keep going. Keep telling us more. It's like a broken record sometimes.
All right, so now we're going to enter into cholesterol. So when it comes to preventing heart disease, you probably heard that it's important to manage your cholesterol, but do you know why? In the next couple of slides, we'll be discussing what cholesterol is and why it's different in men and women. Go to the next slide. So cholesterol is a waxy substance that is found in every cell of our body, as it's important for maintaining its shape. Cholesterol is also important for making hormones like estrogen and vitamins. Cholesterol in our blood comes from two main sources. It's either made by our body, by the liver specifically, or it comes from our diet. So dietary cholesterol comes from animal products such as meat, dairy, and seafood. And the majority of the cholesterol in our body is made by our liver. So in addition to diet, our genetics plays a factor in what our levels would be like. Go to the next slide. As I mentioned, cholesterol is important for your body, but having too much, whether it's from your diet or genetic predisposition, increases your risk of cardiovascular disease. A systemic review conducted by Peter and colleagues, which was published in 2016, took data from almost 1 million individuals and found that total cholesterol is a strong risk factor for coronary heart disease. Furthermore, the effect of this risk is higher in men, although it's a small effect. Go to the next slide. There are different types of cholesterol. The two main types are LDL, which is considered bad, and HDL, which is considered good. LDL can deposit itself into the wall of your arteries and results in the formation of plaques. HDL is considered good because it can help get rid of LDL. Thus,
I remember that L for lousy and H for healthy. So that's one way of remembering. So L for lousy cholesterol, H for healthy cholesterol. There's another fat called triglyceride, but remember L for lousy, H for, and basically you want no LDL, you want no lousy cholesterol. Ideal LDL cholesterol 0, which is not achievable for most of us. And I think you point this out very much, is that all your cells in your body can make its own cholesterol, except for mature red cells because they have no nuclei in them. So you don't need circulating LDL cholesterol in your body, because it can damage the vessels, as you'll tell us about. And you can't get your LDL cholesterol too low is one of the messages right now. Keep telling us more.
Right. So going off of that point, having too much LDL or not enough HDL can increase the risk of plaque buildup in your arteries. And then these plaques narrow your arteries or break off and can result in cardiac events. Go to the next slide. So in general, women have higher levels of the good cholesterol or HDL due to proactive effects of having high levels of estrogen. Hence, women generally have a lower risk of cardiovascular disease. However, it's important to note that as menopause ensues, estrogen levels drop and thus total and LDL cholesterol can rise, whereas HDL falls. Hence, women with normal cholesterol levels earlier in their life can end up with elevated cholesterol after menopause. Go to the next slide. So I sort of have a question for all of you. Have you ever found yourself wandering through the supplement or vitamin sections of a Shoppers or Rexall? Because I know I have. It seems that these products always have such a bold claim, and I always wonder if they actually make a difference. According to Johns Hopkins researchers, after reviewing randomized clinical trials, which included hundreds of thousands of participants who either received a vitamin or placebo, it was found that many supplements did not showcase any tangible benefits in preventing heart failure or other conditions. This was supported by Mayo Clinic researchers who analyzed 277 studies and found that multivitamins, as well as vitamin E, D, and B, did not improve heart health. Both sets of researchers did include that omega-3 capsules did, however, show to help slightly reduce the risk of heart attacks, but more studies need to be conducted to confirm these results. So while some vitamins or supplements may help lower cholesterol or improve blood pressure, which are two factors, if not managed, can lead to heart disease, supplements that claim to have general heart health benefits may be misleading, as reported by Cleveland Clinic. It is important to note that supplement production is not regulated by the Federal Drug Administration or the FDA, nor do these products need to prove health benefits for them to be on the shelf. So often companies can use vague language like good for heart health to market vitamins. Thus, it's important to always look at these claims with a grain of salt. And I know Dr. Curnew wanted to talk a little bit about omega-3s.
Yeah, so what's interesting is that, is for years, the vitamin industry, people say, well, it's an insurance policy. In fact, it's lousy insurance. Is that so? Mention vitamin E. Vitamin E was the wonder vitamin a couple of decades ago. I was involved in a trial called HOPE, and HOPE looked at vitamin E supplementation versus a pill called Ramipril. It was a very easy trial to recruit because people wanted vitamins, but they didn't want the medication called Ramipril, which just lowers blood pressure and blocks some bad hormones. Turns out that Ramipril decreased cardiovascular events by 25%, and vitamin E was totally useless. Mentioned vitamin B or beta carotene. Beta carotene was a wonderful vitamin way back when, and basically beta carotene increases lung cancer, especially if you smoke. Vitamin D affects 25 parts of the human genome, different receptors, and involved everything from loss of balance to bone health to dementia and cancer. And it's turning out the randomized data. So having a low vitamin D level is a marker for bad outcome. You have more cancer, more heart disease. Best source of vitamin D is still getting it from sun, and we have trouble getting adequate sun during our winter months. But it's turning out that most of the vitamin D story is coming out to be negative at this stage. So, what to do with vitamin D is that my vitamin D level was a little bit low, and the best time to measure vitamin D is just as winter ends. So April is a good month to measure. That's going to be your lowest, and what I did, mine's a little bit low, but I'm not supplementing. I'm just spending more time in the sun. And we know that vitamin D supplementation, recent trial one is vital for example. about 25,000 patients were randomized to vitamin D levels. And if your vitamin D was high, normal, or low, giving extra vitamin D really didn't show very much in cancer or heart disease. Now you can torture the data and come up with something. And now one of the things is it involved in decreasing and helping your immune system. We'll have trials in COVID, for instance. The data is relatively mixed, and so far we don't have a strong signal that vitamin D helps in infections right now, but we're still learning. And so it's now become a multi-billion-dollar industry. And basically, the best thing to do is buy your multivitamins and take it for a 30-minute walk every day, and then have your cup of coffee, your glass of water, your best beverage, then take your vitamin. And the benefit is walking your vitamins would be the best important thing. Now, omega-3 is very interesting, is that there's a vegetable form called alpha-linolic acid, found in flax, hemp seeds, and chia seeds. There's reasonable association data, and they're good, healthy foods. When it comes to fish, we have DHA and EPA. EPA is good for the heart. DHA is mostly for brain and your eye health. But the omega-3s that you buy over the counter have a lot of contamination. They're not. They're oxidized. They have saturated fat, which is a bad fat into you. And now even good quality omega-3s, such as trials such as Strength, shows that taking vitamin or omega-3s, traditional fish oils, show no cardiovascular health. Where we have a series of a couple of trials, one's called Reduce It and one's called Jealous, that's showing taking pure EPA at 2,000 to 4,000 milligrams a day decreases cardiovascular events by 25%. So it's giving everybody a headache right now. So if you want to take omega-3s for your heart, the only one that's right now is a medication called Visipa. It's close to $10 a day. It's 4 capsules, relatively expensive, and it will decrease cardiovascular events by 25%. If you really want to get over-the-counter fish oils, make sure you get pure EPA, which is hard to get, pharmaceutical grade, which is hard to get as well. So I think the vitamin story has been just a bust. And by the way, all fish oils increase atrial fibrillation. We're trying to, and the more you take, the more atrial fibrillation that you have. So, wow, what a story this has turned out to be. And it's good for the heart. It's good for the brain. In God we trust. Everything else needs data. And observational data, as you point out, just points the right direction. But randomized data were a computer science therapy, and both you as a patient, you're blinded, and the physician like myself is blinded, because we all have our biases coming in, and then we just count body counts, heart attacks, etc., whatever the outcome you want to measure. So randomized data, big quality data is really important. In the vitamin industry, the food industry has done really more marketing research, but very, very few quality research out there. So lots to talk about. We'll show you a couple of videos for you. I'm going to show you a video later everybody should look at this point in time. And as you point out, it's a non-regulated industry. So a medication has to be approved by Health Canada, the FDA in the States, and so it has to go through rigorous randomized controlled data. And when you put vitamins through that type of data, it comes out neutral or most of the time. So thank you for sharing that. Long discussion for a multi-billion-dollar industry that's out of control.
All right, so just quickly, we have a few examples here. So for example, when it comes to vitamin C, it may not harm your heart and can be taken to support other aspects of your health. However, once again, it doesn't offer any particular benefits for your heart health, although some companies may advertise that it does. On the other hand, it's important to know that vitamin E can actually increase the risk of heart failure and stroke for some people. So it's important to be aware of that. And then we have CoQ10, which is a supplement that has been linked to positive results. Thus, a study on congestive heart failure found that participants who took 100 micrograms a day had fewer major adverse cardiac events than those who took a placebo. So as you can see, it's a bit of a mixed bag in terms of the results. That's why it's really important to speak to your doctor before making any major decisions.
So CoQ10 is very interesting. It's involved in mitochondrial function. Mitochondria, those are the energy producing cells of your body that produce energy. And basically, you want to use 200 to 300 milligrams. There's some data that people get soreness from cholesterol medications that CoQ10 at 2 to 300 milligrams a day might help decrease some of that soreness. The data on muscle strength and things of that nature is basically, it's really minimal. It's quite mild most of the time, unless you have an inborn error in metabolism. The best way to improve muscle function is to exercise. That's the one that works as much. And you need some, and what I'm learning about exercise, a mistake I've made is I did more aerobic activities such as walking, swimming, tennis, running, but you need resistance training, bearing weights and things of that nature, especially as you get older, because muscle mass decreases. Remember, your muscles on an average person, especially if you don't exercise between the age of 20 and 30 to 70, is a 50% loss in muscle mass. And once you hit 50, there's a big decay afterwards. And so resistance training exercises are so important. Adding a little bit of CoQ10 may help a little bit, but it's not that major. And aches and pains, look, I'm 62 years of age right now, and I have an ache and pain every day. If I don't have an ache or pain every day, that means I'm not human. And we always want to bring our medications. So is that most of the time, 90% of the time, it's just our body getting older. And I'm going to try to keep my brain, by learning new skills, keeping my weight down, knowing my blood pressure, my cholesterol, getting better quality sleep, eating sensibly, but every once in a while, I'll take a vitamin just because. I don't know why. Maybe once a month I'll take a vitamin. I have these vitamins for seniors, but in my heart, I know there's not too much. You're going to see a trial coming out that talks about brain health with dark chocolate, which is negative, and there's a little quiz that shows that some of your brain health is improved slightly, but it's you really have to torch the data to make that come up. But basically, there's nothing too persuasive about vitamins at this point in time. Keep telling us more. So this doctor says no vitamins. Here we go. Here's some of these webinars. So this webinar, vitamins and minerals. Didi did a series of webinars. This is a must video. It's long, but it goes through the story about vitamins, but also micronutrients. One of the things is that Mother Nature is wonderful. She really has the magic formula. You mentioned beta carotene. It's 200, 300 different molecules, and taking vitamin Bs increase your risk of lung cancer. But getting micronutrients, eating your fruits and vegetables. I get my potassium from more green leafy vegetables. I get my alpha-linolenic acid from chia seeds, hemp seeds. And beans are the best source of protein on the planet for you. Another one is that we talked about fish oils, and basically this again, a nice long discussion, DHA and EPA. If you want to take fish oils, take a look at this video, and basically the data points to pure EPA, which is important. I wish I can measure an EPA level in you and myself. I would love to know what my EPA level is. And so it looks like DHA is good for the brain and the eyes, and EPA is good for the heart. And you combine the two, you mess up things. So what I'm trying to do is eat a lot more fatty fish on a regular basis. And people who have high triglycerides, low HDL, with these remnant particles, and maybe candidates for EPA. But take a look at those if you're interested. The vitamin and the mineral one, everybody should look at. If you want to take fish oil capsules, look at the one on the one after that. Next slide, please.
And we also have a few.
Now, mention.
Oh, you want to? You go ahead, Dr. Curnew.
Yeah, so this is BNP, pro BNP. This is actually there's a long and a short one. One of the things right now is there's a pilot project in Ontario. Whether or not that will be extended beyond March 2023, I don't know. Someone said that BNP is inexpensive. It's actually quite expensive. It's a $90 test. And so if you do $90 for everyone in Ontario, that's a lot of money. It tells you a lot about BNP, called brain natriuretic peptide. Should be probably named, it's the wrong name because it was first discovered in the brain, but it's contained in large concentrations in the heart. It tells you about the pressure inside the heart. So a number there's different numbers, different ways of looking at it. If your number's over 125 in sinus rhythm, that means that the pressure in the heart may be on the rise. And how to live with congestive heart failure. I think it's actually very important to how to maintain good health, and take a look at that one as well. Next slide, please. These are series of webinars, and this over here is that activity. If you can put activity as a prescription, it has benefits from mental health to psychological health to joint health. If you have sore joints, the best form of treatment is not anti-inflammatories or surgery, is regular exercise to strengthen all the ligaments in your body, and you have less pain over time. Learning how to manage congestive heart failure. We have a series of videos on this. Take a look. So some short ones to some long ones. And it's heart failure. I think you explained it so well, Catherine, but I think it's another good look at, is that I can tell you what to do. I can show you what to do in these other videos, or we can actually do it together in some way. And so we have, on Wednesday nights, we have the mindfulness exercise group. This is a fantastic group. And I don't know why everybody's not part of it. In the sense of you feel better, you learn more. If you want to stay miserable and say, I can't do it, keep doing what you want to do. If you want to change, come join us, or join some other group, but do something. Is that one way to make yourself, longevity is remember quality relationships you have. So really surround yourself with people who want to be healthier and get better and work at it. And you know what? I may never get my gliding license, but I'm really enjoying the process, and I learned so much, and some wonderful people at the SOSA Flying Club that are spending time and helping me become a pilot. If you get congestive heart failure, I'd be glad to treat you. But I want to prevent your congestive heart failure too as well. Next slide, please. And thank you. Thank you for putting up my rambling, and thank you, young people, for showing us how to be healthier. So one of the things to be healthier, surround yourself with young people, healthy people. I'm sure there's a few questions there, Daniel. What any questions there? Any thoughts from anybody?
Not in the chat from what I see at the moment, but there was one comment I wanted to make, because I think what was really important, we talked about this last webinar last Sunday, was and you've mentioned it today as well, you can do anything with the data and associations will turn up, right? And I think to myself, why did all these observational data show that vitamins, had some form of benefit in terms of heart, even though that's not true in these rigorous controlled trials? And my personal hypothesis is, if you're taking vitamins, you're probably a little more health conscious to begin with, right? You're probably doing some more exercise. You're probably watching your diet a little bit better, a little bit more. So I think it's really important to, not just look at a study and take that as fact, but to think about why we're finding this kind of stuff.
You're absolutely right. So people who, I'll give you an example, vitamin E. People who take vitamin E have 50% reduction in cancer, mortality, infections compared to people who don't take vitamin E. People that are randomized to vitamin E have either no benefit or increased risk of stroke or congestive heart failure. Vitamin C, people who take vitamin C have a 50% less risk of infection. People who are randomized to vitamin C have no less infection. And so you're right, it's a marker for being a health conscious individual. And I think associations will actually double risk. Now, it is true that we don't have good randomized data with smoking, but people who smoke are between 50 to 30 times more likely to have lung cancer. People who smoke are 15 to 30 times more likely to have lung cancer. Now, association data is not as precise. You mentioned some of the confounding. We can never correct for everything. We try to, but whether or not it's 30%, 15%, or whatever, you can see that the magnitude, so anything that's 5 times greater from association, I'm sure it's a real effect. If it's a 50% increase or decrease, I don't know. It's just, it's a selection bias because of being health conscious. So I think you're absolutely right. And we also realize that one randomized controlled trial may not be enough. We assign something called a p-value, which means that a p-value of less than 0.05 that means if we did the trial 100 times, 5 out of 100 times will just occur by chance. And so we have very strong data saying that's probably not by chance, but still can be. And so look, medical science goes at a certain pace. It's built on a series of observations initially, then randomized data. And people are tired about COVID and vaccinations in general, but I've learned so much about infectious disease at this point in time. And also too, disease changes, we have to change our thoughts right now. And basically what I learned is that any infection is bad for your blood vessels. So if you get influenza, if you get an attack of shingles, you get pneumococcal pneumonia, or you get COVID, they all damage your vessels. Blood pressure damages your vessels, cholesterol damages your vessels, smoking damages your vessels, diabetes damages your vessels, age damages your vessels. So we have to really fight hard to keep our vessels healthy for long periods of time. When I first started practice, is that 80% of people with heart disease die of heart disease. Now that number is reduced to about 30%, with congestive heart failure coming up as a bigger cause of leading to poor health over time, which is both a success and a failure of our system. And I think right now we're in exciting times because we have so much information, and I spent my entire life trying to figure this out. And I'll be glad to share what I know and don't know. The information will keep changing. And I don't know how anybody can be an expert at everything. I'm certainly not a good expert at flying a glider or running a marathon, but I'm learning from experts, and they teach me a lot. And I hope you take that as well. I'm also thanking all our patients for taking initiative in their health. I'm thanking all our young McMaster and other students for really teaching us about perseverance, hard work, and learning. I'm a lifelong learner. I'm more curious than ever, and having young people around you to make you learn better is good. So thank you for sharing that. And I hope I call myself part of the old farts club. That means I'm at an age in life I can fart anywhere, no question asked. Just kidding about that one a bit. But basically, as we get older, we often become more fixed in our ways. We need to become more flexible. Our bodies are getting older. Again, I'm losing muscle mass, and I'm going to lose less of it by activity, eating right, controlling risk factors. And one of the things is I hope I can improve my brain health by learning new tasks. And one of that for me is gliding. So all those computer games don't make you any smarter, but learning new skills. So for some people, learning to play an instrument, developing a new hobby. For me, it's playing gliding and continued learning and exercising my brain. So I hope you do that too as well. Any thoughts from anybody? Daniel, you get the last word.
Yeah, I mean, I think you said it I just want to emphasize it again. You said it earlier in the presentation. It's mainly just if like going back to making the healthy life changes to prevent atrial fibrillation, to prevent congestive heart failure. Yeah, some of us we'll fall off the wagon, right? If it takes us 10 times, if it takes us 100 times, if it takes us 1,000 times to get back into sort of that healthy lifestyle. I think you just got to keep trying, and you got to keep motivated. So I think just putting in the effort.
And also realize that something doesn't work, got to try differently. You got to be smarter. So if you do the same thing over and over again, it's not working. Well, you got to do something different. And you got to learn to pivot and not to give up. And today we learned a lot about women's health. Women have different presentations of the same diseases. So women will present with more non-specific symptoms later in life for many of our disease processes. And when you're short of breath, ankle swelling, fatigue, it could be so many things, or it could be a combination of more than one things. And we also learned that if you smoke or have diabetes as being female, you carry a higher price to pay for heart disease. At one time you mentioned the estrogens are protective. We thought that giving estrogens will prevent a heart attack. Boy, we got that wrong. Giving estrogens after the menopause actually increases blood clots, increases stroke, increases heart disease. And the observational data was actually very positive. Women who took hormone replacement therapy had less heart disease. But when you randomized to hormone replacement therapy, you actually killed women. You caused more breast cancer, you caused more heart attacks, you caused more strokes, more clots. And it's only through good quality randomized data that we learned. And we learned right now is that we can prevent so much disease. 80% of heart disease and stroke is preventable. So let's do it. And if you haven't, let's treat it. Let's treat it appropriately. So I want to thank the entire crew for such a wonderful presentation. So many good facts and so many good things to learn. So if when you get that email, I'm going to do it next time. Well, if that's what you want to do, that's fine. But I want to learn and get better and make everybody else better around me. And if active kindness, active learning is a good thing. So I'm learning, you're learning. Let's get healthier. Thank you so much, everyone. Have a great night.